Thank you very much, and thank you for the opportunity. As mentioned, I was very fortunate to be asked to lead a task force by the American Society of Metabolic and Bariatric Surgery to revamp the Bariatric Fellowship curriculum to try to transition it to a milestone-based training module. And thank you very much for allowing me to talk about the work that really was a whole task force of people putting it together. We were one of the first societies and fellowship to move in this direction, but definitely this is a work in progress. As I learned more about everyone else's efforts, and I really enjoyed Mark's lectureship today, every time I hear a talk or a lecture or read more about this literature, I realize how much work we still have to do in this space. So I have nothing to disclose. So my goal today was to really talk about the competency-based training modules and to try to show you and share with you how we see that it's different from the traditional training models, as well as describe really what ASMBS has done to use this model to create our new bariatric fellow curriculum. So when we think about the historical model, it was a series of time-based rotations. There were required rotations and there were elective rotations. And for the most part, everyone kept a case log, and everything was always about, have you done enough cases? And have you done the index cases? And have you done the cases you need to be an intern? Have you done the cases you need to be a chief? And completion of the cases was really the surrogacy for competency. If you've done the number of Whipples you're supposed to do, if you've done the number of carotids you're supposed to do, then you were competent. And there were some written evaluations that had to do with your professionalism and whether or not you were nice to the nurses. And all of that was kind of put together, and in the end we said, yes, you're ready to be done. Whereas the competence model is really more about saying that there's just certain things that you should be competent to do as you make the transition from one stage to the next. So when we look at all of us who are aspiring to be healthcare professionals, we sort of say, and I actually, if you look more to the bottom of the slide, there are certain things that every medical student should know when they go from being a medical student to a resident. And there's certain things that every resident should know if they're going to specialize beyond residency to fellowship. And there's probably certain things that every person who has completed whatever their last measure of training is to go on to be an attending. So there have been people already working to say, what are those things to go from being a medical student to a resident? And what we name them has undergone a lot of different things. And in fact, when you read the literature in this space, some people call them competencies, some people call them core competencies, but the naming that seems to be sticking the most is the concept of an entrustable professional activity. And this is the definition that the AAMC has published on an entrustable professional activity. That it's a unit of a professional practice defined as tasks or responsibilities that the trainee is entrusted to perform unsupervised. So it's something that you can see, it's something you can observe them doing. And once you've seen them do it, and you see them do it in a way that you can now say, they can do this independently. I've now observed them performing an H&P, or I've watched them do a lap chole, and they now can do all of the steps necessary to perform that activity that I can trust them to do it alone. So there was a group by the AAMC that created what are being called the core EPAs, that every medical student should be able to do those things before they go from being a medical student to a resident. Each residency group is now starting to work, some are further along in this process than others, to say what you need to be to move along within your residency or to complete your residency. And I think Dr. Minter is actually going to talk about this later, but there is a group working, sponsored by the the General Surgery Milestone Project was put together by the AAMC and the American Board of Surgery to sort of start looking at what that will look like for general surgery residency, and the American Board of Surgery is sponsoring a group to start looking at what that will look like for people who are going to finish general surgery. So now there are several groups, and ASMBS was one of them, that are starting to say, what will these curriculums and EPAs look like for fellowship? And these are sponsored by the Society and the Fellowship Council to try to continue to move this forward, so that we stop talking about time-based fellowships and we continue to talk about competence. But what you really have to do is start from scratch. You really have to say, what's a general surgeon, or what's a hepatobiliary surgeon, what's a bariatric surgeon? And then what are those activities that they absolutely have to be able to do to say that they're ready? And I think it's really important to realize what it is not. This is not a laundry list of cases, and it's not every case that that particular type of surgeon may do in a small town. So it's not Whipples, and it's not vascular surgery cases that a small town general surgeon in Nebraska may have to do. But it is those things that every general surgeon has to do, like evaluate right upper quadrant pain, or right lower quadrant pain, or fix a hernia. Or in the case of bariatric surgery, it's probably doing a sleeve gastrectomy, or evaluating a patient to see if they're qualified and a candidate for bariatric surgery. And you need to have enough of them to give you an idea if they are competent. But you're not going to necessarily see the entire picture just through EPAs. So this is a graphic that one of my colleagues at UNMC and I adapted it from what he's done. So one EPA gives you a little bit of the picture, and then another EPA gives you a little more of the picture. And as you continue to do EPAs, you continue to get more and more of the picture till you generally get the idea that the person is competent. But this is still not all of the picture. We're still going to maybe do 360-degree evaluations. You're still going to have a committee evaluate them to understand, are they professional and how do they treat people? So EPAs are written in a typically very specific format, and they are mapped back to the general competencies that in general were outlined by the AAMC and the General Surgery Milestone Project. For surgery, and here in the United States, we have picked 8 domains of competency. Many of them look familiar because we've been evaluating residents in these domains for years, but several of them were expanded, including adding interprofessional collaboration and expanding some of the professional development. So when you have an EPA, you take your EPA and you say, this EPA is going to evaluate 1 or 2 or 4 of the domains of competency, and then which specific competencies within that domain do they want to do. And I'll give you some examples that might help this be a little clearer. After you have the EPAs and you say, all right, we're going to define what it takes to be a bariatric surgeon, and we know exactly what we have to be able to trust them to do to become a bariatric surgeon, then you write the curriculum. And I think that's the other thing that is really turning this on its head. In the past, we would write the curriculum, and then we would build the evaluation tools to say, are they okay? And now we're going the other way. We build the EPAs, which is the evaluation tool, and now we build the curriculum and say, how do we get someone to the point that they are trustable? And our goal by the end of fellowship is to get them in this competent to proficient range. And ultimately, once in practice, hopefully they become experts. So what did we do in bariatrics? So we know bariatric surgery fellowship is a subspecialty of general surgery, and we knew we didn't want to duplicate anything that's being trained in general surgery. They should come to us competent to do all of the things a general surgeon can do. But we need to take the very specific tasks and EPAs that are specific to bariatrics and move, and some of them may get bariatrics in general surgery. So they may already come with some novice and advanced skills in how to do a sleeve. But we need to progress them along here so that they are competent to proficient. So first, we defined what is a bariatric surgeon. It's a surgeon who has the knowledge and technical skills to care for a preoperative and postoperative bariatric patient. And this includes a series of things that we thought were important, both in the operating room and out of the operating room, and includes bariatric endoscopy. So the current EPAs that we have include a bariatric surgery EPA for sleeves and for anastomotic procedures. There is an EPA for short-term complications such as leaks and strictures. There is a bariatric endoscopy EPA that can be used for both therapeutic and diagnostic endoscopies. And there's an EPA for long-term complications or revisional surgeries. And so here's an example that I took out of the laparoscopic anastomotic procedures EPA. And so each EPA was built, it's mapped to a specific domain. This is mapped to several domains, but for example, in the patient care domain, then it's mapped to a specific competencies. And I'm sorry, the font's a little small, but for example, we evaluate, can they do a thorough history of the patient, and can they appropriately order all of the consults to make sure the patient is really ready for surgery. And you can see how that would map back to inpatient care. Can they gather all the essential information? And so if they're not successful in the EPA, this is a level 1, they cannot identify all the pertinent things. A 3 is that they can do most of it, but not all of it. Proficient is really here. They can do everything they need to do. And we expect our fellows to really be scoring that they can do everything they need to do. And most of our fellows in this one in particular are going to actually be a 5. They should be able to do an H&P. They should be able to do all the consults they need to do. This one really has to do with informed consent. And so can the fellows obtain appropriate informed consent for the procedure they're about to do? There's actually one competency that actually covers every surgical procedure we do, and it's patient care number 1. Perform all medical surgical procedures considered essential for the area of practice. So the EPA actually has every step of the operation. Can they position them on the table? Can they put their trocars in? Can they run the bowel? Can they do the small bowel anastomosis? Can they do the proximal anastomosis? Can they do the leak test? Can they close? The EPA also has a section in it to evaluate, do they respond appropriately to acute intraoperative events? You know, can they manage their OR if something doesn't go well? Can they, you know, does it stay calm, cool, and collected in there, or does everything start to fall apart? And then after we had what we needed to evaluate them on, then we built the modules around that. And the concept of the module is, first you should be learning primary bariatric surgery, then you move on to the next module. So rather than being time-based, you're in a module until you've completed the curriculum. You're competent when you've achieved the milestones that you're supposed to learn in that module, and these are not time-based. And in order to leave the module, you have to meet all of the cognitive and technical milestones associated with it. So these are the 6 modules we came up with that we thought were reasonable to achieve in a year, that we thought by the end of a year in completing all of the modules, you should be entrustable to do all of the activities that were necessary, and that we would turn out competent and even proficient bariatric surgeons. And so I'm going to give you some screenshots that show what are in the modules, but these aren't necessarily complete lists. 2 of the modules only have cognitive multiple choice tests associated with them. 4 of them have both cognitive and technical milestones. So module 1, which is basically the introduction to bariatric surgery, has cognitive things like indications and contraindications to surgery and the ability to work in a multidisciplinary team. So they do have to do things like participate in seminars and evaluations, and they do that through checklists, and then they take a multiple choice test. The primary operation module has some cognitive, so again there's a multiple choice test to demonstrate that they can do these things, and then there is a technical evaluation that almost looks like a little mini EPA in can they do this, but it doesn't span the whole patient as far as getting all the pre-op and the post-op. It's just very technical about can they do the operation. And as you go through the modules, they're like this. But when you get to this module, can they handle and manage short-term complications? This one has an EPA associated with it. So when they get to a point in fellowship where they see a patient with a short-term complication and they have managed enough of these that you now feel they can do it and they are entrustable, then as the attending, you and the fellow get together and realize they're ready to do the EPA as the evaluation for that case, you can fill it out. So again, there's an endoscopy module, a revisional and a long-term complication module that has EPAs that associate with it, and a practice management and quality. And then with this one, again, there's EPAs that are related to primary bariatric surgery. All of this was put together in a manuscript that was just published in this month's version of SWORD. But as I said, we are piloting this with 10 programs this academic year and with 19 fellows. But like I said, if I've learned anything since we put this curriculum and this pilot together, it's that this is definitely a work in progress. This is an incredibly exciting opportunity and space. We've already got ideas, and the working group is going to be getting together because the curriculum is going to change before we roll it out to the rest of the bariatric fellowships, as will the EPAs, because we continue to learn more and more about the best way to develop curriculums. Thank you very much.
Thank you.